So I'm Steve Lamberti. I'm professor of psychiatry at the University of Rochester Medical Center, where I spend half of my time running Strong Ties Community Support Program. That's an outpatient treatment program for persons with schizophrenia and related disorders. And the other half of my time, I'm involved in schizophrenia research. All of the research that we do is treatment research. So we're not doing any MRIs, we're not smearing any chromosomes, but we're trying to figure out the best way to treat people who are facing the challenge of schizophrenia and to assist their families. Now, today I'd like to achieve two purposes, and the first is to discuss what we know about relapse in schizophrenia, what we have learned from research. And also, we want to discuss an early intervention strategy to prevent relapse in schizophrenia. So the first point that I want to make is that this information may be old hat for many of you. For others, it may be new information. But I'm hoping that for everybody, it'll be useful. Now, for most people, schizophrenia is a relapsing and remitting disorder, which means that there are episodes where the symptoms flare up, and in the middle, there are times when there are little or no symptoms at all. Now, how many of you are aware that psychiatrists are about to change the way that we diagnose schizophrenia? Are people aware of this? How many of you have heard of a book called the DSM-4? Okay, everybody knows that. For those of you that don't, the DSM-4 is the book that psychiatrists and other mental health professionals use to diagnose schizophrenia. In that book, there are subtypes of schizophrenia: undifferentiated schizophrenia, disorganized schizophrenia, paranoid schizophrenia. In the DSM-5, those subtypes are going to go away. And I think that's a good thing, because they're labels and they don't tell us much about treatment or prognosis. Isn't that what a diagnosis is supposed to do? It's supposed to make us have a clue about where to go with treatment and what the prognosis is going to be. Now, that's going to go away, and I've been asked to consult to the group that's revising the DSM, and this is what I told them. I said that it's not useful when I'm working with patients to tell them that they're disorganized or undifferentiated or paranoid. It doesn't tell them or me anything. This does. There's a big difference between somebody who's had an episode and a sustained recovery versus somebody who has an episodic pattern with no inter-episode symptoms. You can't tell they're ill at all between episodes, versus somebody with an episodic pattern with inter-episode symptoms, where there are always lingering negative symptoms or cognitive symptoms or even quieter voices. So this longitudinal course of illness is important to understand that for most people, it's relapsing and remitting. And I hope that we pay much more attention to this when we make the diagnosis of schizophrenia, because it does tell us important things about treatment. Now, here's the good news and bad news about antipsychotic medications. We've heard a lot about how important it is to take your medications. Well, here's the good news. We know that antipsychotic drugs cut relapse rates in half. So people who take medications, they'll spend half the time in the hospital than people who don't. It's good news. Here's the bad news. The relapse rates with antipsychotic drugs are still unacceptably high. So even with medications, people can still have a relapse and end up in the hospital. So the bottom line is that medications alone are not enough. They may seem obvious, but it's important enough to say again, medications alone are not enough. Now, I've been using the word relapse, and I just want to be clear. Relapse is a flare-up of psychotic symptoms, hallucinations, delusions, and behavioral disturbances. And it's usually the behavioral disturbances that get people in trouble. I have patients who are quietly psychotic, and they don't get the same attention as they do when there's a behavioral disturbance. That's when the police are called. That's when concern gets raised. But when these symptoms flare up, that's what I mean by relapse. When they flare up to the point that you've got to do something. You've got to call 911 or CIT or go to the hospital. What I want to talk about is how we might be able to prevent that. So, what do we know about relapse? And I'm going to talk in a way that's practical and useful, so I'm not going to talk about the neurobiology of what we know about relapse. I'm not going to get into the genetics. I'm going to talk about what we know in terms of practical management. And here's the first point, that relapse is usually precipitated by some type of stress. Now, when you ask the question, what is schizophrenia? We could say that it's a neurodevelopmentally based brain disorder, but that's not particularly helpful. Here's a more useful way to think about it. Schizophrenia is vulnerability to something in the environment. In fact, a lot of illnesses are the same way. For example, diabetes. People with diabetes, what do they have to avoid? What are they vulnerable to? Sugar, right? Sugar. Gosh, I have no problem with sugar other than it makes me fat, but if you have diabetes, it can make you sick and you'll end up in the emergency room. People with high blood pressure, what do they have to avoid? I grew up watching my mother avoid this. Salt. Yeah, salt. I don't have a problem with salt. I can put on as much as I want. If my mom would use too much salt, her blood pressure would go up, she'd be in the emergency room. Okay? So, what are people with schizophrenia susceptible to? And I'll give you a clue. It's more common than sugar and salt. Stress. Okay? That's the challenge. Stress is everywhere, but it's important to make that connection, and I see if I made it. That's the starting point. Now, I've put together a list of common stressors. These are things that I have seen cause my patients to be hospitalized over the years. Things like illness or death of a friend or family member. That's stressful for anybody. And for somebody with schizophrenia, that can end up with hospitalization. Or not even illness or death, a conflict, a fight with a boyfriend or a girlfriend. A change in a treatment team member. Graduations are special events, so stressors can be good things. They don't have to be bad things. Getting a job is generally thought of as a good thing in this day and age. It can be very stressful. And I've had consumers that I work with relapse because of it. Changes at a group home or a residential program. Changes on the job, money problems, physical illnesses. The list is potentially infinite. A second fact about relapse is it's usually a gradual process. We know that from the first start of relapse until a full psychotic break averages 2 weeks long. For many people it's quicker, for many people it's longer, but on average, 2 weeks. So there's a window of opportunity within which to intervene. It's reversible if it's detected early. A lot of people, when they start to relapse, the feeling is, uh-oh, there she goes, there he goes, there's nothing that can stop it. And we know from research that with early intervention, you can nip relapse off at the bud. And last but not least, relapse has identifiable warning signs. Now, when I say identifiable, we heard today that many people with schizophrenia, maybe up to half, they cannot tell when they're starting to relapse because they're in the middle of it. But if you're looking from the outside, you can see it clearly. So it's very common that family members, friends, loved ones will be able to identify early warning signs. And this is a very common list of early warning signs. One of the most common is insomnia. Some people with schizophrenia never sleep well, but if that person stays up all night, 1 night in a row, 2 nights in a row, that should be regarded as an early warning sign. Loss of appetite. Behavioral signs. These are in some ways my favorite because you can see them. It's hard to see delusions or hallucinations. But I'll give you an example of a behavioral sign. A few years ago, I admitted a consumer to my clinic, we'll call him Michael, and he came with his mother, and my style of practice is to work with the family system, so I invited them both into my office. And as we were walking back to my office, Michael's mother hung back and whispered to me, "If he wears his sunglasses, watch out." About a month later, he came in to see me, and I saw across the waiting room Michael sitting with shades. Sure enough, he'd become paranoid. This was something that made him feel more comfortable. But it was an identifiable and reliable behavioral sign, an early warning sign of impending psychotic relapse. Some people, in an attempt to cope with the noise, with the voices, with the stress, they will withdraw. And that's the first thing you'll see. Somebody who's normally outgoing will suddenly start retreating to their room. You'll see missed appointments, difficulty concentrating. For many people with schizophrenia, the first thing they notice is they start having trouble focusing. And increased psychotic symptoms. For some people, what will happen is they'll start to hear the voices, or the voices will change in tone or character. Now, if we put all of this together, let me walk you through this diagram because this gives you kind of the foundation for relapse prevention. So in this graph, we've got symptoms on this axis. The further you go up, the worse the symptoms get. And we have time across this axis with the different interventions that we can perform. And here we have baseline. This represents somebody with schizophrenia, their usual level of symptoms. For some people, that's no symptoms at all between episodes. For some people, there are baseline symptoms. Whatever, it's baseline. Most people will continue at baseline until they encounter a stressor. And I've made this big red triangle. In my mind, it's like a thorn. You step on it, ouch, that hurt. Life is full of thorns. Love is full of thorns. Nobody is immune. Whenever we get under stress, we show signs of stress. For instance, when I get under stress, when I have a talk to give or I have a grant that's due, I'm not sleeping quite as well. I'm not quite as friendly. I'm a little shorter with people. Each of you, when you think about how you are under stress, we all show signs. It's only human. And the other thing that's human is personal coping. Whenever we get under stress, whether we have schizophrenia or not, we don't just run out and call the doctor. We try to cope with it. It's normal and natural. Now here's where we'll have a little audience participation. Let me ask if any brave person in the audience would care to share how you cope with stress. What is your personal coping skill? What do you do when you're under stress? Yes, in the front. Meditation, yes. Getting centered, getting focused. Sleep, yes. Sleep can cure just about anything to the left.
Go outside and do physical work.
Yeah, physical work, exercise can really help you get calm in the back. Golfing, wow. The last time I golfed, I threw a golf club. But you know what's relaxing for one person is going to be stressful for another. But I got to say, as a group, you guys are way too healthy because what works for me is alcohol, right? Beer. I didn't say coping skills were all healthy, Penny. Chocolate, yes, that's another good one. No, coping skills are not all healthy, but we use them. One last one in the back. Pizza, yes. Pepperoni and mushrooms, please. Caffeine is good, too. That's why they invented it, Dad.
I scream at my wife for eating all that chocolate.
That's right. So if these coping skills are effective, we deal with the stress. We wake up, it's a new day, we feel refreshed. But if you have schizophrenia and those coping skills don't work, then the progression continues. Now, all is not lost because between the simple signs of stress and a full-blown psychotic relapse, there's an opportunity for early intervention if we can spot those early warning signs. And in order to intervene, we need to teach 2 more coping skills. 1 is to identify early warning signs, and 2 is to reach out to your healthcare team when they occur. Now, I wish I could say as a healthcare provider that all of us monitor closely for early warning signs, but we don't. We're still learning as professionals. Usually, when you go to see your doctor or social worker or psychologist or therapist, they begin by asking an open-ended question. So, how's it going? Right? In early intervention, the first thing you say is, so, have there been any warning signs since the last time I saw you? Let's talk more about intervention. I've put together what I call the ABCs of early intervention. Assess for early warning signs, begin intervention, and combat or contact treatment providers. So A is assess for early warning signs. And I've mentioned the early signs questionnaire. It's a 1-page questionnaire that I'm going to share with you in a few moments. And by the way, any of you that are interested in getting a copy of the questionnaire or these slides, I have my email address at the end of the talk. Just shoot me out an email. I'd be happy to share this. But it's important to assess. And we found in our research that teaching consumers and family members, and when I say family members, I'm talking about the circle of support. It could be a mother or father. It could be a brother or sister. It could be a best friend. It could be a landlord. It could be a case manager. But who's ever in that person's circle, teaching them to use this questionnaire. Once early warning signs are spotted, it's important to begin intervention. B is begin intervention. And one of the hallmarks is trying to identify that stressor. It's like pulling the thorn out of the foot and creating a low-stress environment. So you've heard a lot about give them space. The officer was talking about that strategy when somebody's in full relapse. It also helps when somebody's on the way to relapse, giving them space, creating a low-stress environment, being calm, speaking with I statements instead of you statements. Those become very important. And also, consider what we call PRN doses of medication. That means extra doses as needed, because often that can help somebody feel calmer. And then last but not least, to contact treatment providers and saying the right things. It's important to say that early warning signs are present and to try to get a crisis appointment. Now, let's practice. Let's put this together. This is a fact-based hypothetical vignette involving Lisa. So Lisa is a 29-year-old woman with schizophrenia who lives with her mother. One morning, her mother discovers that Lisa stayed up all night and tried to cut her hair with a pair of scissors. The first question that I would ask, and that you might ask as a family member or friend, has anything changed in Lisa's environment? Sometimes it's easy to identify a change, sometimes it's not. But there's usually something that has changed, some stressor that's out there. So we look for it. You almost have to be a detective to find out sometimes. Well, as it turns out, Lisa's trusted therapist is leaving the clinic, and Lisa's being assigned to a new therapist, which would be stressful and frightening. Now, let me ask you, do you think that Lisa's behavior represents anxiety over changing therapists or early warning signs? How many of you say anxiety? How many of you say early warning signs? It was a trick question. I heard the answer over here. It's both. It's both. The two are one and the same. The anxiety over that fight or that lost job or that new therapist, that is what triggers the early warning signs. So here is where communication becomes important. We've heard it mentioned again and again today. What should Lisa's mother tell the treatment team? If Lisa's mother calls the clinic and says, or if Lisa herself calls the clinic and says, I need an appointment, you'll get the next available appointment, which could be anywhere from a few weeks to a few months away. That's not going to help. In our research, which I'm going to be showing you, we arranged an appointment within the next day. Or if it was on a Friday, there was an appointment first thing Monday. A better language to use is Lisa's having early warning signs of relapse and she needs a crisis appointment. Early warning signs of relapse and needs a crisis appointment. Depending on your clinic, they may handle that in a variety of different ways. They may have crisis slots available. They may know exactly what you're talking about, or they may be mystified. But these are the right words to say. Now I want to show you the power of this simple little idea in some research that we published a few years ago in the Archives of General Psychiatry, where we compared this approach, monitoring for early warning signs and intervening quickly, with treatment as usual. We did this study at Strong Ties Community Support Program. This is our outpatient program in Rochester, New York, for people who have schizophrenia and related disorders. We have about 1,500 consumers, and we offer a variety of services. There are clinic services. We had day treatment services for a long time, case management services. We have family groups, family services. We have peer services. The people that we recruited into the study, there were 82 of them. They were ages between 19 and 60, and they had a diagnosis of schizophrenia or schizoaffective disorder, and all of them had had at least 2 hospitalizations. So this was a group that had been in and out of the hospital a couple of times, at least 2 hospitalizations. Many of them had more. So half received treatment as usual, which means that they would be seen by their doctor, their therapist. They would get open-ended questions like, so how's it going? Any problems with your medicines? The other half received regular monitoring with the early warning signs questionnaire. So every time they came into the clinic, we would sit down and go over this one-page form. And it looks a little daunting at first, but it's really just a yes, no checklist about, since the last time we saw you, have you had any trouble sleeping, any trouble eating, any problems concentrating? It takes a while to use this form because the first time you go over it with family members and with the consumer, there are going to be a lot of yeses. Because as I mentioned, often people with schizophrenia never sleep well, or they're always feeling anxious. So those aren't early warning signs. Those are baseline signs. Once you get to know a person's baseline, that's when you can be much more effective in preventing relapse. So we would have this form filled out. Often patients would bring it in whenever they saw us. Sometimes family members would bring it in, and we would fill out one right during the session. And if we saw a prodromal symptom, then we would see the patient again within 48 hours. Typically, we would see them the next day unless it was a Friday, and we would see them on a Monday. Also, we carried a beeper 24/7, and that was something which made the therapists on my research team a little bit nervous because they were afraid that patients and family members would be calling at all hours for no good reason. And what it turned out is patients and family members got very good very quickly at knowing when to call and knowing when not to call. So we made a real emphasis to monitor and to have them contact us quickly when there's an early warning sign. We considered that a crisis. We didn't wait for it to become a real crisis. So this is what we found. This is 18 months. And there are 2 groups. The treatment as usual group, those are the circles at the top, and the program for relapse prevention group, those are the squares along the bottom. And this is what statisticians call a survival analysis. And what it shows us is how many people ended up in the hospital after 18 months. Well, what it shows is that in the treatment as usual group, across the top, or rather the program for relapse prevention group, this is the group across the top where we monitored for early warning signs. In the program for relapse prevention, only 15% of the patients had a hospitalization within 18 months. 85% were hospital-free. And this was a group that was having frequent hospitalizations. But look what happened in the treatment as usual group, the squares. The treatment as usual group, by the end of 18 months, about 65% had been in the hospital at least once. So almost 4 times the relapse rate. And we didn't do anything with medications. All we did was monitor more closely for early warning signs of relapse. Now, this slide summarizes again the 3 ABCs: assessment, beginning intervention, and contacting treatment providers. And I wanted to point out that this strategy is simple, but it's not easy. Got that? Simple, but not easy. It takes practice. I often tell the medical students and residents that I work with that if a patient that you're working with relapses, that's bad, but it's not all bad. Because if you and the patient and the family can go through a couple of relapses together, you'll get a good view of those early warning signs. And early warning signs tend to be the same early warning sign from relapse to relapse. It's not always 100%, but somebody who tends to have insomnia as the first warning sign of illness, of relapse, they'll always tend to have insomnia. Or that patient of mine who tended to wear sunglasses when he got paranoid, whenever he got paranoid, he always wore sunglasses. So if you can go through a couple of relapses together, you can learn the early warning signs. So it's simple, but it's not easy. It takes practice. And it feels awkward to fill out a little piece of paper, but it becomes something that people could do in 10 seconds once they memorized it, and it's not that long of a form. Remember that stress can cause relapse. Often it feels like relapse comes from out of the blue, but stress is what's causing the relapse. And sometimes it's hard to pick up on the stressors. I had a consumer several years ago who was doing very well, hadn't been hospitalized in 3 years, was attending day treatment, living in a residence, working part-time. One day he showed up to my appointment and he had shaved off his eyebrows. And I knew that that was his early warning sign. So we checked with the group home, there was no problems there. The job site, no problems. The day treatment program, no problems. It wasn't until I called the patient's mother and I found out that the week before, the patient's little brother had graduated from college, which was something that he had never been able to do. Once you know what the stressor is, you can deal with it, but you have to look for it. Picking up on early warning signs is key. Reporting early warning signs to treatment providers is key, and using the right language to do that. And intervening early, because we know that we can nip relapse off at the bud with an early intervention. Now, I'm mindful of the time. I wanted to give you my email address for those of you that are interested in a copy of the Early Signs Questionnaire, and also a paper that goes along with it, which talks more about the strategy of early intervention. I don't know if we have time for questions. I'm told we have a few minutes for questions, so I'm going to open it up to the audience. Questions, comments? Yes, in the front.
Do you believe that there's seasonal stressors? It's just the season.
The question was, do I believe that there are seasonal stressors? Absolutely. I have clients who every spring they start to get manic, and I have others that every winter they start to get depressed. So that's another reason why it's important to follow somebody and work with somebody closely over time. It's called continuity of care. It's an old idea, but the more that you can identify seasonal variations, the more helpful it is. And it's the kind of thing that you can tell a clinician. I may have a client that I'm working with who says, absolutely, under no circumstances do I want you talking to my family about treatment. And they have the right to do that. But if the family member calls or writes me a note and says, by the way, just want you to know, I know my son's treatment's confidential, but I want you to know that every year around the fall, that's when he tends to get sick. If I have a family member telling me that, they just gave me a head start in helping that person. So absolutely, yes.
And a follow-up question, so the intervention is going to be an increased med? Is that always going to be the case?
It's increasing the med and decreasing the stressor. You have to do both, and sometimes you can manage just by decreasing the stressor. About a year ago, I had this patient, Lisa, who was starting to relapse because the therapist she'd worked with for years and poured her heart out to was leaving. She got very anxious, had early warning signs, but we knew what the stressor was. So what we did was we got the new therapist and the old therapist to meet with Lisa together. And that passing of the torch, that just put her at ease, putting a face to the name that she was no longer anxious. So it's not always just medications. There's a question in the back. Okay. Yep, question in the front.
Question. In this hypothetical situation where normal life is a stress, so let's say my son is not taking medication for a while, then he gets to a hospital, then after that he takes medication, but as he establishes himself in normal life, he wants to go to college, he starts applying for school or something like that. That in turn makes him stressed, and then in turn he relapses again.
Yes, that's one of the challenges of recovery, is that many people will manage their own illness by really putting themselves in a low-stress environment where they're not leaving the house and not moving forward with their life, but it puts them in kind of a holding pattern. If that individual takes the next step, starts to take medicines, gets better, then gets a job, and has to deal with a mean boss, or gets a boyfriend or girlfriend, then has to deal with a broken heart. These are the challenges of recovery. And yes, they will face those as recovery progresses. On the left.
What do you do if your child won't take medication because of associating it a negative side effect with memory loss?
Yeah. So the question is, what do you do if a child does not take medication? I wish we had more time to talk about this, but it's important to provide education, to work with treatment providers, because some medications do cause, they're more anticholinergic than others, and people may experience more memory loss. So providing choice, providing options, and working with the person. Side effects are very common, and the only way that our medicines differ, it's not effectiveness, it's side effects how they differ. So it may be possible to find an alternative. Okay? Yes?
And this is a question in response to what do you do when life stressors are under stress. And I'm wondering if part of that would be working on increasing or teaching more personal coping skills. I mean, would that be part of maybe the prevention?
Absolutely. We've been talking about decreasing stress. Yes, there was a... Yes, it was actually thank you, a very helpful comment. An audience member suggested that as consumers recover and they enter more stressful environments, that perhaps the ballgame isn't decreasing the stress, because what are you going to do about a boss or a jealous boyfriend? The game becomes increasing coping skills. That becomes the strategy for managing stress. And that's another part of recovery, is improving coping skills. And we talked about some of our coping skills that we already use, and there are others that can be used. Yes, in the front.
I'd like to say something about what do you do if the person is going through stress and you suggest certain things to do differently, and then that turns into an argument or a fight. Because you know you have the best interest, and they know it too, but at the moment when you say, wouldn't it be nice you don't stay up the whole night and you do stuff during the day and you go exercise and do something, and then it turns into an argument or to a fight.
Yeah.
Because the person is not wanting to do what you suggest.
Yeah. So the question is, if you have a loved one who is at risk for relapse, and you make a suggestion about how they might be able to cope, and they don't listen to you, unfortunately, it puts you in the same position as coaches across America. You know, coaches will tell their players, this is what I want you to do, and sometimes they listen and sometimes they don't. But you hope that they will learn from their experiences. I remember I was in that situation with a patient of my own a while ago. I gave what I thought was this brilliant advice. My patient didn't listen, ended up in the hospital. We were talking afterwards about, well, what have you learned? And he told me, well, I'm never going to do that again. And I said, well, it sounds like you've learned. And he looked at me and he said, Doc, I may be crazy, but I'm not stupid. So you hope learning occurs. On that note, ladies and gentlemen, thank you very much for your time.